Welcome to Clinical Thinking Lab Episode 2. Today's case is about acute adrenal crisis with malignant hyperkalemia. But the deeper relation is not just adrenal crisis. The deeper relation is clinical decision making. When a patient is unstable, the question is not only what is the diagnosis, the real question is what is the immediate threat and what decision cannot wait. In this case, the immediate threats are hyperkalemia, hypoglycemia, and shock. Let's walk through it. A 58-year-old woman presents with 3 days of weakness, nausea, vomiting, and dizziness. She has rheumatoid arthritis and has been taking prednisone 10 mg daily for 9 years. Her vitals are concerning. Blood pressure is 76 over 42, heart rate is 116, respiratory rate is 22, oxygen saturation is 98% on room air. So immediately, this is not a stable patient. She is hypotensive, symptomatic, and it reeks of rapid deterioration. The history of long-term steroid use is very important here because chronic steroid use can suppress the hypothalamic pituitary adrenal axis, and if the body cannot produce enough cortisol during stress, the patient can develop adrenal crisis. Her lab shows sodium 121, potassium 6.6 with peak T waves on ECG, glucose 44, creatinine 2. This is a dangerous pattern: hyponatremia, hyperkalemia, hypoglycemia, hypotension, and chronic steroid use. Together, this should immediately make us think of acute adrenal crisis. But at the same time, the potassium is 6.6 with ECG changes. That means malignant hyperkalemia is an immediate, life-threatening emergency. So clinically, I need to think in two layers. First, what can kill the patient in the next few minutes? That is hyperkalemia causing ventricular arrhythmia or PEA arrest. Second, what is the underlying diagnosis driving this physiology? That is adrenal crisis. My most likely diagnosis is acute adrenal crisis, complicated by malignant hyperkalemia. The evidence is strong. She has chronic steroid use, she is hypotensive, she has hyponatremia, she has hyperkalemia, she has hypoglycemia, and she is clinically unwell. A dangerous alternative is septic shock because sepsis can also cause hypotension, AKI, lactate elevation, and altered physiology. A physiologic mimic is acute kidney injury causing isolated hyperkalemia. But AKI alone does not explain the full picture as well. It may explain hyperkalemia, but it does not fully explain hypoglycemia, hyponatremia, shock, and chronic steroid risks together. So, adrenal crisis becomes the unifying diagnosis. This is the important reasoning point. Hyperkalemia is not the whole diagnosis. It is one dangerous manifestation of the underlying adrenal crisis. The immediate threat is twofold. First, malignant hyperkalemia can cause ventricular arrhythmias, cardiac arrest, and death. The peak T waves tell us that potassium is already affecting cardiac conduction. So calcium must be given quickly to stabilize the myocardium. Second, adrenal crisis can cause persistent distributive shock. Cortisol normally helps maintain vascular tone and vascular responsiveness to catecholamines. Without cortisol, the vessels respond poorly to endogenous norepinephrine and epinephrine. So the patient can become severely hypotensive and even develop refractory shock. That is why we cannot treat this as only an electrolyte problem. We must treat both the immediate hyperkalemia and the adrenal crisis driving the shock. My management hierarchy starts with airway breathing circulations, cardiac monitoring, IV access, and resuscitation. Because this patient has ECG changes from hyperkalemia, I would give IV calcium gluconate immediately. Calcium does not lower potassium, but it stabilizes the cardiac membrane and reduces the risk of fatal arrhythmia. Then I will give insulin with dextrose to shift potassium intracellularly. A beta agonist can also be considered. Because she is hypoglycemic, dextrose is especially important. At the same time, I would give IV hydrocortisone for suspected adrenal crisis. I would also give isotonic IV fluids, usually normal saline, because adrenal crisis often presents with volume depletion and hypotension, as in our case. And I will look for a precipitating cause such as infection, missed steroid doses, vomiting, dehydration, or another acute illness. Now, the attending asks, why not wait for the serum cortisol level before giving hydrocortisone? My answer would be, I would not delay hydrocortisone while awaiting cortisol results because adrenal crisis is a clinical diagnosis requiring immediate treatment. This patient has shock, chronic steroid use, hyponatremia, hyperkalemia, and hypoglycemia. That combination gives a high pre-test probability of adrenal crisis. Cortisol deficiency reduces vascular responsiveness to catecholamines, which can lead to refractory hypotension despite fluids and vasopressors. So, in this setting, hydrocortisone is life saving and should be given immediately. If it can be done without delaying treatment, I would draw serum cortisol and ACTH first, but I would not wait for the result. Draw blood quickly if possible, then give hydrocortisone immediately. The diagnosis can be confirmed later. The patient needs treatment now. Now the case changes. 15 minutes after treatment, IV calcium gluconate has been given, insulin and dextrose has been administered, hydrocortisone has been started, 2 liters of normal saline have been infused. Now the potassium improves from 6.6 to 5.8. Glucose improves to 112. The ECG changes are improving, but the blood pressure is still 74 over 40. This is a very important moment. The potassium treatment is working. The glucose has corrected, but the patient remains in shock. So the question now is what is still driving the instability? At this point, we should not keep focusing only on the potassium. The remaining problem is persistent shock. The potassium is improving, but the blood pressure hasn't. What is your next step? This patient has persistent shock despite appropriate initial therapy. She has received fluids, hydrocortisone has been started, hyperkalemia is improving, glucose has normalized, but she remains profoundly hypotensive. So, I would start norepinephrine to maintain organ perfusion while continuing definitive treatment of adrenal crisis. The reason is physiology. Hydrocortisone does not work like epinephrine. It does not instantly raise blood pressure. It acts partly through genomic mechanisms. So, restoration of vascular responsiveness takes time. Norepinephrine bridges the patient. Hydrocortisone repairs the physiology. So, the updated decision is start vasopressor support, continue steroids and fluids, monitor potassium and glucose, and manage the trigger. The first call from this case is treat the immediate threat and the underlying disease. In this patient, hyperkalemia is the immediate threat, but adrenal crisis is the diagnosis. If we only treat the potassium and forget the adrenal crisis, the patient remains at risk. Second Paul, do not delay hydrocortisone for cortisol testing when adrenal crisis is strongly suspected. Draw blood first only if it does not delay treatment. Third Paul, reassess after every intervention. Initially, the problems were hyperkalemia, hypoglycemia, and shock. After treatment, hyperkalemia improved, hypoglycemia corrected, but shock persisted. So the focus shifts. Now we treat persistent distributive shock with vasopressors while waiting for corticosteroids to restore vascular responsiveness. That is the kind of reassessment that matters on call. What I learned today is that clinical reasoning is not static. At the beginning of the case, I had to treat malignant hyperkalemia immediately. But I also had to recognize that the bigger diagnosis was adrenal crisis. Then, after treatment, the case changed. The potassium improved, the glucose corrected, but the blood pressure did not. So, the decision changed from potassium stabilization to persistent shock management. That is the real lesson. Good clinical care is not just giving the first correct treatment, it is reassessing what improved, what did not improve, and what physiology is still abnormal. In this case, calcium protects the heart, insulin and dextrose ship potassium, hydrocortisone treats adrenal crisis, fluid supports circulation, and norepinephrine maintains perfusion, while the steroid effect catches up. So the final takeaway is hyperkalemia was the emergency, adrenal crisis was the diagnosis, persistent shock was the decision point. This is Clinical Thinking Lab episode 2. One case, one diagnosis. See you in the next. Thank you.